rest of her talk. Thanks, Carla.
Thanks, Wade. I appreciate it. And I want to thank Chasm actually for, first of all, putting this on and also including me in the schedule. I think it's a great organization, a great group of people, and I really appreciate how they bring in the mental health aspect of things. As you all know very well, pretty much everybody that walks through your door could have some challenges with their mental health. So I appreciate the opportunity to speak to you guys about this stuff and be a part of you. My goal is to not make you all into psychiatrists or counselors or therapists in any way, but at least to increase your comfort level with what you might see, have an idea what to look for, have some radar items, and then have a bit of an idea of what to do with that when you see it. And you don't need to necessarily treat it or become the expert on it, but maybe have a network of people you could reach out to for some support as well. I will share my slides with you. Okay. So this topic is on the mental health and the elite cyclist. So, I mean, everybody has mental health. Some people have mental illness. We're going to talk a little bit about the impact of the sport on the individual's mental health and how it can compromise it at times. And then what we can do as physicians or other people who support the athletes in identifying it and knowing what to do with it. I have no interesting conflicts, wish I did, or conflicts of interest to disclose. So we will proceed. All right, first of all, I want to talk a little bit about just general psychological experience in typical elite cyclists. It's not all about illness, but our athletes from whatever sport they come will have a varied psychological experience within their sport at any given time, which is influenced by performance, life stuff, physical components, dynamics with team, personality. There's a whole wide range of things that can influence your psychological experience. So I'm going to highlight some of those things to you. I'll also bring forth some common mental health presentations, which can be more on the pathological side that you might see in cyclists in particular, but again, it can be applied across all athletic fields. Talk a little bit about comorbidities or differential diagnoses that you can have in your mind based on how they may present in a certain way. We'll talk about the serious mental illnesses that they can have, and then really try to bring in an approach so that you know what to do with that if you see it. There's an article published just a year ago, really, that looked at the mental health of elite cyclists. If you had saw my talk a few weeks ago, you would have seen that there's a wide variety of pretty heavy things that can happen in this sport. It is a dangerous sport. We can have catastrophic injuries. We can have deaths directly related or affiliated with cycling in some way. And it can have a big ripple effect in the population. In addition to that, we do have a lot of elite sport related issues that can affect mental health. And the question was, does elite cycling have a problem with mental health, and what are they actually doing about it? This article in particular highlighted a number of athletes who really struggled with severe mental illness and came close to ending their lives, and really looked at their systems of support to see if sport itself had enough of a structure around them to really support it. So I think it really shone a light on some of the challenges and gaps. And I think Canada's doing a pretty good job in trying to fill those gaps right now. So this graph here, it's not scientific in any way. It's one that I put together really to just capture some of the variations that I see in a lot of our athletes. Again, this is a typical athlete who's not struggling with mental illness and what they may go through from a psychological spectrum of experiences. So let's look furthest to the left. Let's say they enter a training block, they're excited to train, they're bringing some energy, they're excited to be back with their teammates. You know, they reach a plateau, they may not be happy about their numbers, they're getting pretty tired based on how much work they're doing. They may have a bit of conflict, you bring everybody back together again, there's going to be conflict at some point. They may not perform as well as they want to. Then you can see a big decline in their level of satisfaction. It may not equate to a clinical depression per se, but a pretty big drop in their personal satisfaction, their affect may be pretty low. At the bottom, they can present with low mood, anxiety, lack of motivation, against performance failure. It may affect their sleep and their appetite. They can be avoidant of therapy or treatment. They can be avoidant of their teammates, and they may resist rehab. We see sometimes that people just don't show up when they're supposed to, and that can be a direct result of this type of profile. After there's some sort of intervention, hopefully some support for them, they can climb back out of that and they can start to feel a bit better. They can get some momentum back. They can regain their goals, their passion. They start to feel better again, feeling good, ready to compete. Then we see them back on the way up. Another training block, excited to train, excited to return, and hopefully they hit their performance peak, top of the world. Let's hope that's the next major games that we have, peak performance. After a peak performance, it is very, very common, or even just a major games, very, very common for athletes to have what they call a crash within the first 3 weeks after a major games. Typically something like a multi-sport major game like the Olympic Games, sometimes after World Championships, a little bit less commonly, but you think about the Olympic cycles and such, it's 4 years of building up. They sacrifice a lot of things and then they hit it, the pinnacle and collection of everything, and then it's over. And then it's either thinking about the next 4 years, which is a long time, or then life thereafter. It's life altering. So we know this, we can predict this, and I think we need to prepare our athletes better for that. So where do we start in trying to assess the mental health of our athletes? What I like to do is understand the population that you're dealing with, understand the sport, understand the challenges, and then work yourself backwards to figure out where you can identify some of the challenges early on before they become challenges. So one of the questions would be, what factors can affect mental health and well-being in elite cyclists? And with elite cyclists, you can substitute in rowers or track athletes or hockey players. These are some of the things that we know exist in the world of these highly skilled individuals. In cyclists specifically, they have long training rides. For people like me who are not cyclists, a long ride for me would be like maybe an hour. These people go for 5 hours at a time on a daily basis. There's often weight restriction, comments about how they look. You know, some of them think lighter is faster. In normal times, there's often extensive travel seasonally. It's not uncommon to see a cyclist be at their home base only for 3 weeks of the year, and in other times hopping around the globe going from competition to competition. As I stated in the first talk that I did a few weeks ago, there is very likely a history of crashes. Some of them are quite significant, or else they've known of other people who have had crashes or traumatic injuries. Altitude training is something that is quite often done to prepare for a competition that's going to be held at altitude or to enhance performance in a legal way. But it's not good for everybody. And it's been a question that's come up for me a number of times with a variety of sports that train intentionally at altitude to, again, get a performance advantage physiologically. Altitude training does alter oxygen supply, obviously, and physiologically it does a whole lot of complex things. But from a mental health point of view, it can affect mood and energy. They struggle at the beginning of it. And I would say that for those who are struggling anyway, to put them in that environment that's going to have a physiological effect like that puts a greater strain on the system, and you need to be aware of that. I've had a hard time finding really good studies about this. I'd love to actually do some of the research on this, so maybe down the road. But it's something that I want you to keep in mind for any of your athletes who are going to train at altitude. Ask them about their mental health. Try to understand if they have a history of depression, and try to understand what their risk factors are at that given time. And there have been times when athletes that I've been involved with have been advised not to go to altitude for that reason, because of the risk. For a lot of these athletes, again, they sacrifice everything. They put everything on hold for that Olympic cycle, and it becomes their lives. They have total immersion into the program. They live where they work. They live with whom they work. And then there's the dating. And we know that in sport, it can be quite incestual in the way that, you know, these are young athletes at the prime of their young lives, and they tend to date a lot. So it can be challenging. It can create some certainly programmatic challenges, and when it doesn't go well, it can affect things on a grander scale. So definitely need to be aware of those things. There are some external challenges as well that can pose stress on these individuals. One is the lifestyle of the elite athlete, again, including changes caused by the pandemic. So we have a group of people who are used to having their entire day completely structured from start to finish, with when they eat, what they eat, when is training, what they train, when they rest, when they get up, and suddenly there's no structure. And when that shift happens, it's quite disruptive for them. So pressure to perform is always there as well. I've heard from a number of athletes that they've heard from their coaches, if you guys don't win, I'm going to lose my job, or we'll lose our funding, we won't have a program anymore. These young people have a lot of pressure on themselves anyways to perform if they also assume the burden of funding for a program as well. It's going to cause undue and unnecessary stress on these people. Again, the pressure to get points in sports like cycling or triathlon, where you have to accumulate points over a period of time to qualify for the Olympics. There's a lot of pressure for that, and that's strategically placed to determine who goes around the globe and when. And then the question of who gets to go. This isn't the case in all sports. In some sports, you qualify yourself and you go yourself. In sports like this, you qualify a team and then a squad is selected based on a lot of different parameters. But within a 4-year period, a lot of things can change. And the people who go to one Olympic Games, they're in the Olympic pool, and there's always in the Olympic pool automatically. And then other people need to get into that pool to try to get to the next games. And it's sometimes very difficult for people who are working really hard in between the games to get into that pool, to be a contender to go to the next games. But those who were at the Olympics and step away for a few years and then decide to step back into that pool the year of the Olympics, it makes it really difficult for those people who've been working the entire time, because they may not actually get a spot to go. So that it's a very unusual dynamic, and it's really difficult in a team sport to be able to encourage people to support each other when there's a lot of that internal resentment and competition that can happen. Again, who gets to go? This is an exceptional year in that obviously people had planned to go to Tokyo in July and August, and a lot of people had planned to retire and move on with their lives afterwards. And this exceptional circumstance has required people to make a decision about whether they go forward with their plans or they continue to put their life on hold for another year. And some are somewhat in between in a hybrid model of moving on with their life, but still foot in the door to go to the Olympics, and they still have to decide if they're going to go. So again, a lot of extra pressure. We know that within sport, there's bullying, harassment, and abuse, which is a whole other topic on its own, and maybe we'll do that another time. And we have done it other places, but it's a big thing, and it does exist in cycling, and Safe Sport is there, of course, to help us with that. And a negative or toxic team dynamic. So anytime you bring together a group of people, no matter what sport, no matter what organization, not everybody's going to have the same agenda, not everybody's going to have the same work ethic, and there can be, you know, with intense individuals who are very competitive, a lot of judgment. So it's very important for the IST to be aware of that, for the coaches to have that on their radar and address it, because team culture is so very important for the mental health of everybody involved. Internal factors that can drive the impact on mental health can be whether the person is fully immersed completely 100% in their sport versus balancing it with something else outside. So is their only social circle their teammates and other people at the velodrome? Or do they have people outside the cycling community that they can have just normal conversations with about non-cycling related issues? Or are they involved with school, either as a prep for later or something to balance things out? We know that for elite athletes, training and competition is their job. It's really hard to have time to work anywhere else. So it's hard to really stretch out beyond that, but it's really important if they can. Relationships and family, of course, are things that can either be really healthy or unhealthy. And as I said, having a life outside of cycling is important. Injuries can affect people, either old chronic nagging ones, new ones that pop up, again, depending on the cycle of where they're at in terms of competition, how close it is to the games, how likely it is for them to interrupt their chances, how likely it is for them to regain their pre-injury success. A lot of factors with injuries that can affect them. And life transitions, again, around games is super important. Identity is something that we often talk to athletes about. The athletes whose identities are completely locked in with their athletic lives tend to struggle more. Those who can recognize themselves as an individual who does something really well and has great opportunities to compete and travel the world, they have a very different experience. Because when they come into the life transitions, those who have an identity outside of their athletic identity are able to transition much more easily into other forms of life than just their athlete life. So in some sports, we address that directly And we try to help athletes prevent it from having their sole identity as their sport. And of course, medical issues as well. Then there are the exceptional factors. These aren't as common, thankfully, but they are things that can impact their mental health. Again, significant injuries, return to play, any significant interruption in training or competitions can affect their psychological status. And some of the other issues that I just talked about in terms of their likelihood to return to pre-injury success, the chance of being replaced by someone else on the team, all of those come into play. So anytime you have an athlete in any sport with any significant injury that interrupts time, competition, or training, usually for 3 months or more, please pay attention to their mental health. Deaths and catastrophic injuries of teammates, we've talked about before, and again, deaths and catastrophic injuries within the sport, or I would say within sport in general, because if they've experienced it before and it's been a trigger for them, just hearing about any type of situation in any sport may be a trigger for them as well. So just be aware of that. If you're aware that your athlete has had an experience like that and something else comes out in the news, just check in with them. I think it could be very helpful. In terms of specific mental illnesses in cyclists, there is little to no research on the incidence of specific mental illnesses in cycling itself, other than what I can tell you about what I see and what's in the media. So I can tell you for sure that a lot of the athletes that I see have major depression, clinical major depression. There's a lot written about athletes and their major depression in the media as well, and mostly because they come forward with their own stories. A lot of them have subsyndromal anxiety, which just means they have symptoms of anxiety that do not fulfill criteria for a specific anxiety disorder. Whenever there's a concussion, you can have post-concussion mood changes. Sometimes that can be from a physiological change or physical change, but sometimes it can be in response as an adjustment to the interruption in their training and their competition afterwards. In my previous talk, I talked about Kelly Catlin, who committed suicide a couple of years ago, and her family noted that her mood changed significantly after her concussion the previous fall. Her brother felt that it was because she just couldn't tolerate not training. It was he said, really, literally driving her crazy not being able to train. But every time she trained, her symptoms became too large, so she wasn't able to. But she also developed depression aside from that as well, so it was kind of a double whammy for her. ADHD is quite common in cyclists, I have to say. It's not uncommon actually at elite athletes anyways, because a lot of these athletes, their medication, their treatment is their sport, and they can have a lot of success in their sport even if they have ADHD until they reach a certain point. Similarly in school, really great athletes tend to be treated differently in schools. They have a different schedule. They have, again, their days are way more structured because they have to get somewhere at a certain time. But at some point they're more independent, and that's when they can run into trouble with ADHD. So any athlete who's competing at a high level, international level, would need a formal ADHD assessment, a therapeutic use exemption form if they require any treatments that are prohibited by WADA. Insomnia is very, very common in cyclists, partially due to the schedule, partially due to the globe hopping, but also they take high levels of caffeine before they race at night and then have to sleep and then somehow get up in the morning for the next races. So sleep schedules can be quite off in this group of people. Grief can be related to a lot of things. Again, straight up losses and death, loss of their athletic identity, loss of their career when they move on, lots of different things to be aware of. And PTSD as well. If you have an athlete who has had a significant crash in whatever sport they're in, please always screen for PTSD. And there's simple questions like, do you have nightmares about the accident? Do you have flashbacks during the day where you're awake, but something happens and it kind of brings you right back to that moment again? Those are flashbacks. Are they having panic attacks? Are they on edge? Think about PTSD because it can be very, very common in sport. All right, so if you see an athlete who you feel is depressed, like anything in medicine, you're going to have a differential diagnosis. Scott Shallow a few weeks ago talked about overtraining syndrome and talked about a lot of the common factors that you can see as well. They don't have energy or motivation. They feel quite lethargic. There's some screens that you can do to look for that, but there are some subtle differences as well. Rest will help. Overtraining syndrome won't necessarily help depression. So if you think you have an athlete who has overtraining syndrome, but you're wondering about depression, it's not a bad idea to get a second opinion from a psychiatrist just to figure that out. Always want to check nutritional deficiencies, medical abnormalities, rule out anything sort of medical. That's a common thing to do. Any endurance athletes or athletes who are weight restricting, you want to think about REDS, or relative energy deficiency in sport. If you've ever read the publications, you know there's a whole lot of circles around that REDS diagnosis. Is no longer just a triad, and psychological is part of that, and it can look like depression. They just don't have enough fuel to fight the sadness. They don't have enough fuel to generate coping mechanisms, can present as depression. Another common sign, actually, a lot of coaches will reach out to me and say, I think this person's depressed because they're not showering. They haven't showered in 2 weeks and they're really smelly, and I'm worried about their self-care. So sometimes that's the easiest sign for people to pick up that people are struggling behind the scenes. Depression is an internalized disorder, and they hide a lot of things, but when their appearance starts to be challenged, you can see that. Sleep tends to be off. Adjustment disorder, again, I talked about if there's any interruption in training for any period of time, they can have either anxiety or depression in response to that. The pandemic certainly caused a reaction in a lot of people. The difference that is between adjustment disorder and depression is that adjustment disorder typically starts after a specific event and is more commonly time limited. It usually resolves within a couple of months after the stressful event, but it can develop or graduate into a depression if it goes beyond that and has significant disruption. So again, be aware of timing, try to make some correlations. Again, with depression, if there's a concussion, there could be correlation there. And then just simple dissatisfaction about performance. What's the timing? Do they feel really bad after they had a really bad performance? It may be related, in which case you would think more of an adjustment reaction type of thing. In terms of anxiety, very common to have situational or performance-related anxiety. For some, it's about job security. If they don't perform, they don't get a spot. And there's always that pressure to perform. And I would challenge you to find me a high-performance athlete who's not perfectionistic in some way or have really high standards for themselves. In part, it drives them to be as good as they are, but it can get in the way as well. Anxiety can also be related to poor self-care. So if they're not eating enough, if they're not sleeping enough, they can't cope and they have a lot of anxiety. So it can be just simply related to lifestyle. Caffeine use is going to make their nerves jangly, and they're just going to feel on edge and have all of the physiological changes related to that. So if someone presents with anxiety, always ask them how much caffeine they're using. Anxiety can be a medication side effect from antidepressants or stimulants. Again, adjustment disorders as well can present either as disrupted mood or anxiety. So again, with anxiety, get a sense of timelines, what's happening. Thyroid function, I think Scott also talked about thyroid abnormalities in athletes. So thyroid can affect energy levels. It can look like depression, but it can also look like anxiety if it's hyperthyroidism. And post-concussion can look pretty much like anything. So if you have anyone with mental illness symptoms and it's post-concussion, it could be related to that. In terms of serious mental illness, the goals are simply identify what the key issues are, figure out how you're going to manage it right away, and know when to refer. I think everything exists on a spectrum, from low risk to high risk. Anything at all you can place on a spectrum. So if an athlete is presenting to you with symptoms of ill mental health or mental illness, you just need to figure out where on that spectrum they are, and then have a little bit of a game plan as to what you're going to do at the various parts of that spectrum. So in terms of high risk, these are the things that you need to have on your radar. If you have an athlete who's in such an emotional state that they lose the ability to be rational, that they can't engage in conversations about the future or maintain their emotional control. So this is an athlete who is just inconsolable, either crying or rage or just panicky, and you just can't break through with any rationality. Have it on your radar that they may not be able to contain themselves or control themselves. So they may need some more help at that point in time. Other side of that, loss of hope, despondence, loss of passion for sport. They don't care. They don't care if they make the team. They don't care if they go to the Olympics. They don't want to hang out with their teammates. It's a significant change in their demeanor, so they can go from someone who's pretty social and pretty upbeat to not. That's a big red flag. If there's any evidence of self-harm or destructive behavior, those are signs that you really need to pay attention. And if you see any of these things, I would put them on the high risk side of that spectrum. Some of the case studies we talked about before, including Kelly Catlin, post-concussion depression with loss of training and a threat to their career. Those are three big things that place them at extremely high risk for suicide or significant depression, okay? So if you see that combination of things, have it on your radar. I would highly recommend you get psychiatric support for that. If you see agitation, anger, conflict within the program combined with mental illness, so I mean, athletes can get angry, they can get agitated and be ticked off at their coach, fine. But if you get that combined with a significant mental illness and a threat to their identity as a rider, so this is the person who, this is all they know. They live there, they train there, it's their life, and suddenly there's conflict in their life there, and it's challenging their future, that can put someone on the edge. So if you can see that degree of conflict, have that on your radar, get some help. Also, if a person has a previous history of mental illness and a recent exposure to or experience of catastrophic injury, their own or others, that's high risk too, right? So let's person with significant history of depression and then a big trigger of a life-threatening event, it could be a trigger, a bigger trigger for them. And it could either send them spiraling backwards to where they were before or worse. So again, have that on your radar. I would put them at the high risk end of the spectrum. Somewhere in the middle would be post-concussion symptoms of mental illness. So these are things that you want to pay attention to. You definitely want to pick up on your screening. And if you pick it up, then you want to perhaps have a deeper conversation with them about it. Maybe involve, one of the NPCs or a psychiatrist, but definitely look into it a little bit more. If they have a past history of depression, self-harm, anxiety, during high periods of stress. So these people may be doing okay most of the time, but when they're under more stress, they just may need that extra bit of support at that time. Not emergent, but a bit of support in a timely fashion would be a good idea. And recent exposure to or experience of a catastrophic injury within the program, just be aware that it does affect everybody. Even if they weren't their training partner, they knew them and it's going to affect them. So be aware of that and at least make sure that it's addressed on some level by somebody. And dissatisfaction with performance. Again, these athletes are not always going to be happy with their performance. I probably should add on to that dissatisfaction with performance and a history of mental illness. That in itself would just put them at a higher risk for re-exacerbation of syndrome, of their syndrome or their symptoms, and just to pay a little bit more attention to that. And the lower end risk of the spectrum is just a past history of mood disorder or anxiety somewhere in the past. You pick it up through screening, they've had a history of it, you put it in their medical record just to be aware that that's there, just so that there's some correlation. If anything else happens in between, you might need to do something about it. They probably don't have any suicidal thoughts or a major event has happened. So again, a disruption, a little bit of a disruption in their mental health, but nothing major. Or if they have subsyndromal syndromes, meaning a little bit of anxiety, a little bit of dysthymia or low-level sadness, but nothing that's getting in the way of things, they would be something that you may want to address, but on the lower end of the spectrum for sure. And those who are managing well overall. So there are some that from time to time will just say, I need some help with this, my sleep is off, need some help with that, my energy's off, need some help with that. Otherwise, they're managing well overall. You might need to get them some support, but they'd be on the low risk end of this mental health spectrum. All right. Oops. So now let's talk about what to do with it. So you identify where they are in the spectrum. Here's your approach. So know your audience. Again, understand that cycling is a high-risk sport and it's almost always guaranteed that cyclists will have had exposure to significant crashes, either themselves or others. So start by asking the right questions. So for example, have you ever had a crash? We talked about this a few weeks ago. Have you ever had a crash? How bad was it? What happened? You ever have flashbacks or nightmares about it? That rules out PTSD. How's your mood? Mood's okay. Any big lows? Rules out depression. Any problems with anxiety? Very, very simple, open-ended questions. That'll give you hits or misses from that point of view. From a clinical approach, you can screen for symptoms of mental illness. And we talked a little bit in the past few weeks about some screening questionnaires that you can use. There are some that are used in the literature quite a bit. The POMS, I think, CED is another one. These are common ones that we use in varsity athletics and a variety of NSOs. Very simple public domain ones. The GAD-7, PHQ-9 are going to look at anxiety and depression. The athlete sleep satisfaction questionnaire is one that's being used more commonly for sleep disorders in athletes. ASRS for ADHD screening, the Beta-Q for eating. The athlete psychological strain questionnaire, there's a really good validation for that, and it has nice cutoff values for figuring out when your athlete is struggling. The SMAT is a new screening tool that's been released by the IOC very recently. It's a sport mental health assessment tool. The idea is that it would be administered in the field by athletic therapists or anybody, scored kind of like the SCAT for concussions, and it has actually embedded in it a lot of the other scales. So the GAD-7, the PHQ-9, the ASRS or the CAGE questionnaire are actually embedded in the SMAT, and it captures them all. And you can create a system where if they surpass a certain threshold, that will then guide you to referral to the appropriate services. Always evaluate possible medical causes, look for comorbidities, try to identify contributing factors, so what is going on in their lives right now to contribute to the problem, and evaluate their level of risk. So from a management approach, you want to do, again, the medical rule outs. You want to involve anybody who can look at lifestyle and help them with lifestyle balance. And then support, so suggesting mental health support. So do they need psychotherapy? Figure out what the severity level is. NPCs can help cover lifestyle and performance challenges. Psychologists can help if they need some more intensive psychotherapy or treatment of depression, anxiety. Psychiatrists would get involved to help assist with some of the medical evaluations and prescribing if necessary, and collaboration in that regard. And in terms of when to get psychiatry involved, I would say consider it strongly for the moderate severity. Consider initiating pharmacotherapy, and I'll talk about that in a second. And I would highly recommend that you refer all high-risk cases to psychiatry. It's worth it. It's better to be a little bit overreactive in this case, because you can't take it back sometimes. So definitely refer the higher risk folks. Whoops. Okay. I don't know where my other slide went with the pharmacotherapy. So in terms of pharmacotherapy, there are algorithms that exist out there in terms of approach to ADHD and anxiety and depression. You can treat the athletes with any of those agents. Just be aware of the WADA guidelines and the prohibited lists, and also have an awareness of the side effects. Obviously, you want to avoid agents that can cause weight gain or sedation in some of these patients or some of the athletes, because those are unwanted side effects for sure. So in summary, just to wrap it up, all athletes are at risk for mental illness. They're not an exceptional group that are exempt from mental illnesses. The rates of mental illness are at least as high as the general population, and I would argue probably higher in certain things. We know that in aerial sports or aesthetic sports, eating disorders certainly are more prominent. The characteristics of elite sport contribute additional vulnerabilities related to their lifestyle, high stakes, pressure, performance, and sport-specific risks itself. And most of these athletes are away from home, so always be sure to explore their supports. Who's around them? Who do they talk to? When are they going home again? And how do they feel about being away from their family for so long? And particularly with COVID, that just introduced a whole lot of other things. Regular public domain screening tools can be used anytime. They're validated. You can use them in athletes. Use any of these at any time. Consider the SMAT. I think it is published and you can access it. See how you can embed it within your programs. It's pretty easy to administer, and again, it can be administered by the ISTs. Very helpful. Athletes fulfilling criteria for mood or anxiety disorders can be treated with the usual agents, as I said, but just be mindful of the unwanted side effects. There are a few medications that do cause weight gain and sedation, so you want to stay away from those. And be aware as well of the WADA prohibited list. Some great psychiatrists are a phone call away, so don't hesitate to reach out if you have any questions about what's useful and what you might want to try. And finally, athletes can have severe mental illness. They can get very ill. It's very important to recognize the symptoms, try to figure out where they are in that spectrum, and figure out what the appropriate approach is going to be for them. Better to err on the side of caution than not, so don't be afraid to reach out. I'm happy to field any questions. I have to figure out how to work this Q&A thing. Wade, I'd appreciate your support if you can have it.
Yeah, and just waiting for if anybody does have any questions, please put them in the Q&A and Dr. Edwards can answer them. There isn't any there right now. Okay. Maybe while we're waiting for that, I'll just, Carla, is there, like, it's very easy for me to access you because I talk to you all the time, but for areas of the country where maybe people like you aren't as easily accessible, is there any suggestions about how to access advice from a sports psychiatrist in different parts of the country?
Yes, so I'm in the process of getting together at the Canadian Association for Sports Psychiatry. So there's a group of psychiatrists from across the country who are individuals who either are treating athletes currently or are expanding their practices. So I'm going to link us with CHASM, and so that will be a resource, hopefully, that we can publish the list of access to them, and they can be an email away or a phone call away or a referral away. So it's coming. I'm available now. People can email me anytime with a question. I don't mind. But hopefully we'll have a more robust network across the country in short order.
Thanks, Carla. And so first question posted is, what is your usual drug of choice for starting an athlete for depression? Yeah,
good question. So it depends on the comorbidities. If it is straight up depression, there's nothing else, there's no anxiety, Wellbutrin is a pretty good choice. It targets the noradrenaline dopamine systems, doesn't cause weight gain, and it doesn't cause sexual side effects. And that's a big one in this population. They're young people, and you need to know that any of the serotonergic agents have the potential to have sexual side effects, which would be not desirable amongst these folks. So I mean, you can educate them about the other options. So SSRIs or an NDRI like Wellbutrin would be my top choices. But Wellbutrin if there's just depression. If there's a significant anxiety component, Wellbutrin won't really do a whole lot for that. So you're probably going to have to choose a serotonergic agent. None of them are on the prohibited list, so it would all be pretty safe. The one I would typically start with for an adult aged athlete would probably be Cipralex or escitalopram. It's very well tolerated. It's pretty weight neutral, doesn't have any sedating effects. Just one of the things you have to be mindful of, again, with any of the serotonergic agents, when you're looking at analgesia, is combining them with an NSAID could cause bleeding problems because they all have antiplatelet effects, and combined with NSAIDs, you could run into that. So if you're starting someone on an antidepressant, the safe thing to do would be to advise them to use acetaminophen for analgesia rather than an NSAID.
And last question, just a question regarding caffeine and sleep. How do we best address this combo?
It is tough. It is tough. And to be honest, during season and racing season, it's just about getting them to sleep and getting them to race. And in between, they try to normalize it. And a lot of them have difficulty. So it's not uncommon for athletes to need sedating medications to have with them during competition. So in terms of what medicine, like some just use Benadryl. You need to be mindful of where that fits on the list and how much they can use. Zopiclone is a pretty safe one to use. We don't have very many options in Canada, but Zopiclone is a pretty easy one to use. It's not prohibited. They just have to be mindful of the hangover effect. So smaller doses and only when needed would be preferable for that. Otherwise, they might get rebound insomnia. Otherwise, they're going to use their caffeine. You can't avoid that. They're not going to stop that. So it's about balance during the season.
So just two more questions, then we'll move on to the next talk. I'll touch on this one because you brought it up. How often do you really see NSAID and SSRI combo bleeds?
I see more commonly easy bruising rather than bleeding. And depending on, again, if they're in a sport, if they're a boxer or something that may cut them, they might have more difficulty clotting and may bleed more. But in terms of other athletes or other sports, they do bruise quite easily, and it's not uncommon. So I would warn everybody about it.
And the last question for live answer. There is one other one in the Q&A function. You can actually type the answer to after Carla. But the last question is, for an athlete with depressive symptoms after concussion, do you have any contraindicated molecules?
Any contraindicated what?
Contraindications.
Oh, contraindications. For antidepressants or for? anything? I'm just wondering, where's that question?
It's not actually my question. It's in the chat, so I'm not.
Okay, I'm trying to.
It's not in Q&A. It's actually in the chat. That one's in the chat function.
Okay, can you repeat it? Sorry.
So it's written, for an athlete who has depressive symptoms after concussion, do you have any contraindicated molecule?
So does that mean medications that I would avoid?
I think so.
I would say not really. I mean, the books that you would read about potential side effects of antidepressants with post-concussion headaches in particular, they often talk about SSRI-related headaches or NDRI-related headaches. It's not actually seen very commonly. So for significant depression, I think it's pretty safe to use most agents. I mean, some of the more common agents that I've seen that can cause headaches are things like Prozac is one, but we don't use it very often other than in kids. So no, I think I've used many different agents for the headaches. You just have to watch for any drug interactions because you have other docs prescribing for the headaches themselves, and you just need to make sure that you're looking for any drug interactions to avoid any problems.
Okay, that was great, Carla. That was a fantastic talk as always, and very, very helpful. There is just a couple of questions in the Q&A. You can actually type the answers if you want, one from David Brooks and one from Connie Lebrun. And then we'll move on to the next two talks there. So I'll leave them open for you.
Thank you.
And then if we can switch over to Richard, and Richard, if you can pull up your talk. And you can mute your screen there. Okay, so moving on to our second talk, I'm going to introduce Richard Maclean. Richard's a physiotherapist I've worked with for many, many years, and a triathlete and avid cyclist himself. He has been involved in doing bike fit as part of his physiotherapy practice for quite some time now, and I asked him to speak on kind of the nitty-gritty of what you need to know about bike fit and some practical tips. And if you were at the session last year, it was very, very well. We are doing this obviously virtually this year is a little different than hands-on demonstrations, but I think Richard has some very helpful videos. So I'll let you go ahead, Richard.
Excellent. Thank you very much, Wade. I appreciate you inviting me to come out, and I'm glad that Chasm is having me out as well. Obviously, it'd be much nicer to do in person, but this is great that we're getting to do this and getting to hear such great talks from everybody. So I'm going to talk to you about bike fitting. The athletes that I tend to work with are your recreational athletes up to age group, up to more advanced age group athletes. I don't tend to see for bike fitting the national guys and national women. They're going to have people that within their circles that are well experienced and people that they put their trust in. And so most of what I'm going to talk about today is stuff for the physicians that are dealing with more the average population, but again, up to people that are quite aggressive in their training and have pretty strong goals despite not being national caliber. So my background, I've been a physio for 20 years now and working mostly with athletes. Back in 94 to 2006, I was a competitive triathlete, which is where I first got introduced to looking at bike fitting. I was pretty anal in trying to put every piece together to perform as best I could. I was able to compete. I progressed up to Ironman distance races by 2002, and at Ironman Canada was able to qualify for Hawaii and went and raced Hawaii that year. So I studied bike fitting for a few reasons. One of the big ones was how much it changed my abilities. It just took the efforts that I was applying and seemed to get the most out of them. So knowing that there's other people like myself that are trying to maximize their effort, I wanted to be able to help them, but also knowing that there were injuries that were coming along with it. So I had patients asking me as we were trying to rehab their injuries, could this be my bike fit? And to be honest, I didn't have the answer for them. And even though I had studied bike fitting quite a bit as far as reading through literature and that, I didn't feel like I was competent enough to bring them in and actually make changes to their setups for fear of either not helping them or potentially making it worse. So I also wondered, because of the situation that I was in, were there patients that were falling through the cracks? Were there physios like myself that were doing the best that they could to try and help them rehab, and bike fitters that were doing the best that they could? But there were people, tough cases in the middle there that neither group could figure out for sure. And so I wondered if I could be that guy that could help marry the two and help in those challenging situations. So I looked at and went down to study tri-bike fitting with a fellow named Dan Empfield, who was kind of the leading edge on triathlon bike fitting at the time, and still is really. Obviously, there's lots of other really good people as well, but he was one of the forerunners. I also went to study how to adjust the shoe, foot, pedal interaction in order to help with bike fitting as well. And the fellow that I studied with there is a guy named Paul Zwift, and he's a multi-time national track champion in the States. And so I asked him, did you ever race Kurt Harnett? And he said, yes, many a time, and unfortunately I never beat him. So that was kind of nice to hear, because I remember watching Kurt in the day. He used to kick butt all the time, so it was fun to watch. And to declare I have no conflicts of interest. The only conflict I have is in my life these days is loving and hating the Leafs all at the same time. So as a sports med physician, why should he care about bike fitting? I think a big part is that in order to understand the stresses that these athletes are putting themselves under for repetitive strain injuries, you need to be able to look at the ergonomics of being on a bike and the forces that they're applying and sustained postures that they're applying. So having a sense of what changes can be made to reduce those stresses while they're still trying to maximize performance is going to help you out with giving them good advice. If you don't have to obviously be able to do a bike fit, but if you can ask good questions, and when you're hearing their feedback, point out some issues that you have concerns with, then that's going to help you have good conversations and help guide those athletes. The other part to bike fitting is that, and it happened to me a few times, is that because bike fitting wasn't being addressed, I had patients that would keep coming back with injuries that we thought we had resolved. And then in the end, you realize that you had to change the ergonomics. And it's not unlike having somebody who works in a poor desk situation the whole time, and they're getting repetitive strain in their forearms because the desk is not set up well. You need to change that in order to have a long-term success. So kind of a quick and dirty way of thinking is someone walks in your door and they're having injuries and issues with riding their bike is, do you send them for a bike fit? Do you send them to physio, or do they need to go to both? I would say if someone comes in and their symptoms are pretty mild, you do a clinical exam and you're not seeing anything that's jumping out at you as really significant that screams that it needs rehab, it may be good to try the bike fit first while things are in their early stages. And then once you take away those stresses with a well-fitting bike, it may resolve itself and they're back to their normal, happy athlete. I would send to physio first and ignore the bike fit if the clinical signs and symptoms are significant. So if you go to check their leg strength and knee extension, resisted knee extension is 3 out of 5, and they're in quite a lot of pain, I don't think a bike fit at that point is going to help them. They need to get those tissues healthier before you can go and take a look at the ergonomics. And then if someone kind of falls in the middle, you may want to send them for both. The other reason to jump on doing both at the same time is looking at what their demands are. So if they say, hey, I've got this event 8 weeks out, what should I do? How do I get rid of this? Then you want to bring everything on board all at once and try and resolve it as quick as you can, so that they can get some good training in before that last event and feel like they've gone into the event with full recovery. So in the bike fit process, what I like to do is I still approach it like a physio. And I know that I'm not the only person to go through and ask questions, but obviously as a physio, you're asking questions in a slightly different way, a little bit more detailed. But you're also asking them what are their goals, what are their current complaints, previous injuries, previous training volumes, because ergonomics is one thing, but if they've also gone from 5,000 kilometers of riding and now they're doing 12,000 kilometers of riding in a year, their bike may fit them quite fine. They've just progressed themselves too fast. So I'll also go through and do a physical exam. I'll focus on wherever their issues are while still taking a look at both upper and lower quadrants. The process is usually at least an hour to 2, depending on how complex it is and how quickly someone can sense what feels right to them. Because the way I do the fitting is again, one that's advocated by Dan Enfield, and that is that you take people through various positions and have them tell you what feels best. You use the angles that are kind of expected people to fall within for the various joints as your guidelines, and the farther to the edge or even beyond that people say, oh, this feels good, you start to get a little worried and you try and corral them back in. But it's not set in stone. And so if they're at the low end of knee angle and they seem to move well and it feels good to them, you're going to have them try that, and then you're going to review with them several weeks down the line and see how they're responding to that. I've started adding on two-dimensional tracking of live tracking of knee angles. I used to use a goniometer and plumb bob and things like that, and not that there's not still use for those, but as you start to see the use of tools like Retool, which is a infrared laser system with cameras that can pick up three-dimensional motion, there's more of a push to go to these live angles, and there is some advantages to that. So I ran across a paper recently that was kind of interesting. They did an experiment, and they wanted to see how consistent our bike fits, and it was their hypothesis that there might be quite a varied approach. And so they took 3 athletes and sent them to 9 different studios, and then took a look at what each person did. And there was quite a big variety in what was done. So as a physician or even as a physio, if people are getting a bike fit done, it's good if you can know local people in the area that seem to be pretty consistent in their approach, because you can get quite a difference in how someone would be set up. And some of the errors that they were seeing were they were ignoring guidelines and going just by how people felt. So, it's pretty commonly accepted that at the bottom of the pedal stroke, bottom dead center, that knee flexion should be around 30 to 40 degrees in active motion. And that if you're outside of those, you're likely going to incur some injury and decrease performance as well. So there's a number of things that can be adjusted, and this is a decent list, but there's more than this. Picking a good saddle, something that suits both your discipline and your body type. There are female specific saddles, and I'll leave more of the discussion on saddles to wait. But know that that's an important part. If someone comes in to see me and they don't like their saddle, then we're likely wasting our time going through all the adjustments, because that contact point is so important for them. Saddle height is one of the main parameters, and we know that from the research that it significantly affects injury, and it also significantly affects performance. So that's one that you want to nail really well. The saddle fore aft is often set depending on what discipline you're in. If it's road bike, you're often trying to get your knee over pedal spindle. It's called COPS. And it doesn't mean that that's the absolute right position for everybody, but it seems to work well for most. So you're adjusting the saddle to get you around that position. You also then want that to end up in that you are in a good cockpit length. And the cockpit length is the distance from your saddle out to the handlebars and your contact, whether it's in aero bars or it's on the hoods and the handlebar itself. You want that to be a decent distance so that when you are lean forward into that position, it's not taking a lot of effort to be there. The saddle angle, most commonly, and it does vary again depending on what position you're in. If you're down in a time trial or a triathlon position, you may need the saddle tipped down a little bit more, but in general, it's either level or slightly tipped down. The handlebar width is picked on road bikes in relation to your shoulder width. So if you reach your hands out like so, you should be able to fall down into your handlebars quite nicely. Now, some people will buy narrow handlebars in order to try and be more aerodynamic, but that does run the risk of it being less comfortable and create more strain. One of them that's quite interesting and I think probably underutilized is adjusting the crank length. And I ran across that myself, and it was one of the questions actually when I went down to work with Dan Empfield was, can you adjust the crank length without impacting performance? Because when you look at somebody who has restrictions in flexing their hip, they still want to be able to get forward bent so that they can be competitive, but not jam that hip together as they're going through that top dead center on the pedal stroke. So if you can use a shorter crank, you can still be in the exact same angling through the hips and shoulders, and so nice and flat and aerodynamic, but not pinch on that hip, so you're taking away that impingement. So it was pretty nice to see that the research looking at crank length shows that it has minimal effect on cycling performance, especially in endurance. It seems to have a little bit of reduction in 30-second power, but for guys like myself and a lot of the road riders and time trialists, that 30-second power is less important. It does create some compensation, though, that when you go to a shorter crank, you tend to use a higher cadence. That's a pretty natural occurrence. So the research also strongly shows that when you're determining saddle height, common methods in the past used to use a percent of your inseam or percent of hip height. They've been shown to be to be quite poor in that when you use those methods, a majority of the time, your knee angle isn't going to end up where it should be in that 30 to 40 degree range. So if you ever had a patient come in and in your discussions you realize that that's how their saddle height was set, you'd probably want them to go get that rechecked. Another thing that can be changed to improve positioning on the bike is looking at how your foot is contacting the pedal. So if you have knee tracking issues, so instead of being like a piston, the hip, knee, and first two toes are nicely lined up and you're driving straight up and down, if there's any kind of circumduction in or out, those are strains that and potential loss of power that you'd want to correct if you can. And so with the cleat, what you can do is undo it and you can move it in or out in order to bring the foot out or in. And you're trying to bring that foot in line with where the knee is and then see what happens. Sometimes there are angles that you can use, so wedges that will take up space to help with that alignment. One of the other ones that's kind of neat is that if you have a wider athlete, so you know they have a wide stance, bigger hips, the bikes are pretty narrow for them, and so if you have someone who's 5'4" and quite slim, they shouldn't be standing on the same pedals as somebody who's 6 foot and has quite a wide stance. That really doesn't make any sense. That's going to add stress to the bigger athlete. So pedal spindle width can be adjusted. There can be the over here these little spacers. You can add in a couple of those without compromising the safety of the contact of that pedal onto the crank. And then if you need something larger, there are these devices here. Now that's 20 millimeters, so that's quite a big adjustment, and you have to put it in and then see if it fits, if it's now brought that person to good alignment. And Speed Play, which is the type of pedal that I run, they came out with various lengths of spindles, and other manufacturers have come out with that as well, which kind of solves the spacer issue. It's nicer if it's all one unit. So those are options again if you're looking at your athlete and you think, wow, they stand pretty wide, so you can have them stand in front of you and just march and look what's their natural stance. The other part of it in looking at that stance is you can look, do they externally rotate? Do they pigeon toe? And your cleat should then be adjusted according to that to match what's natural for them. It may look kind of funny on the bike if you look at somebody and they're pedaling pigeon toe, but if that's how their body naturally moves, that might be the best position for them rather than trying to stick them straight. So this fellow came to see me. He had just picked up a new tri-bike and was having issues. A big part of his issue was discomfort up in the shoulder and the neck. So I thought I'd show you the front view for him first, because it did bring up some issues to me in that he's got pretty wide shoulders for his height and he's tucked in pretty tight. Good for aerodynamics, but again, that might have been part of the factor for why he was getting discomfort on reasonably short rides. So within an hour, he was starting to feel some discomfort. I also thought I'd draw on here because we did take a look at his knee tracking. And I didn't set this one up as a video, but you can see that the markers that I put on the first and second toe up to the tibial tuberosity on both sides, it nicely lines up. And pretty much through his pedal stroke, it was sitting quite nice. So we didn't have to make much adjustment there. I think with him, I did look at adjusting so that his foot moved a little bit more forward over the pedal spindle. You do want that pedal spindle to be sitting between just behind the first MTP and just in front of the fifth MTP, so that you can get good pressure through the MTPs as you're pushing down. This lady here, I believe she's 42, had come to see me. She's a recreational athlete, and she had inherited this bike from her husband. And 99% of bike fits that I do, they have the bike already, and they want me to fit it to them as best they can. Sometimes it's a stretch, and this was one of them. So I wanted to show you, this is a side-by-side comparison to what I was seeing. She had actually come for therapy first. She saw one of my colleagues and did quite well. Her hamstring strain improved to nearly full recovery, but she still had some ongoing issues, and she was having SI joint issues and low back discomfort with riding. And she was riding 3 to 4 to 5 days a week, 40 to 60K distance. So let's see if we can get that to run. The left side is the after. No, that's the before. Let's see, I might have to pull this up. So looking at this video here, this bike was too big for her, and I could tell that right from the start. You can see that her hands are well back from the hoods, so she's having to rest here, and her arms are almost completely straight. The other thing that's quite interesting, I wondered, or I thought, no wonder you're having issues with the your hamstring and SI joint and low back, is look at how much she bounces because of her positioning. So normally, in order to get that position to be more reasonable, you'd be working from both the front end and the back end to meet in the middle. With her, she already had the shortest stem on her that she could. So the best I could do was bring that seat forward as far as we could and then optimize her saddle height. And so if you look at the right side, see how quiet she is and her hands are now on the hoods. So when I contacted her last and asked for permission to use this video, her cycling was going great and she was quite happy. That being said, I did tell her that it would be a really good idea if she could, when it was time to get a new bike, you can do a screening to find out what bike size you should get. There's not every shop will have it, but people like myself will have fit bikes where they can throw you on there and they can give you numbers to help you go and find a bike so that it's in the right range. And then once it's in the right range, you can adjust stem length and things like that in order to get it to fit well. So it was nice that we were able to have that success with her, and because she really did not want to buy another bike at this point. So this is that fellow again, Richard, and he got this beautiful bike for a great deal and wanted to fit to me, but because he had spent money that he had hidden away from his wife, he didn't want to spend any more. So looking at it, I wasn't sure that we were going to need to spend anything, but as we worked through it, I brought him as far forward as I felt was comfortable. I brought his seat angle up to a fairly steep 81 degrees, and his biomechanics looked pretty good, and we did close in. He just looks a little long through the front. So when you're looking right in here, that angle is just a little bit tough. So if you're doing a plank, you want to fall forward onto that and hold yourself easily. The farther forward your arms are, the harder you're going to be working through here. So I think that was the main culprit to his discomfort. Now let's take a look at the bike. So he doesn't look terrible here, but he was definitely having issue. And as we moved him forward, he reported less discomfort. And then the thing that was kind of cool is, look at how much quieter he is through the trunk here. And he's not moving around a lot, but just that little bit more. So you're just fine tuning it for him, right? Now I did tell him if the shoulders didn't resolve, he would have to buy a stem, and I have a fit stem. So you throw it on there and it can adjust. We can find how far do we have to pull it back. I actually thought it was kind of silly. This stems are not that expensive, especially compared to buying a whole new bike. I'm sure he could have slipped that one in there unnoticed, but that was his choice. So one of the things that I've added into how I do bike fits, and this program here is called Canovia. It's actually used in research in universities. It's free shareware. So you can, when you take videos, you can apply this model and it will go through and track angles for you. So you can get dynamic measurements, and it'll spit out curves over time. And so you can see that it follows the markers, and will show you the dynamic angles. And so you can see as he gets down to the bottom, he's getting down to 152 degrees, which is well within that range of what you want at bottom dead center. One thing to also know is if you're ever talking to somebody and looking at it and comparing static measurement versus dynamic, is dynamic always ends up with a little bit more knee bend by measurement. Even if it's the exact same angle, just the way the process works, so you can't compare numbers directly for those. All right, and then I was hoping that I might be able to demonstrate the benefit of a shorter crank, because when I ride, you'll be able to see that on this side here, I get a bit of a skip because there's some tightness in through here. And so I already ride 165 mil cranks in order to accommodate for that. And it's perfectly fine on a road bike. But if I go down into TT or triathlon position, you start to see some negative effects to that. So it's just this little hitch here. Not painful. And I didn't even actually notice it until I saw it on video, and my kin student who was working with me said, "Oh, you got a little skip going on over there." And then it's just quieter over here, and also a little bit more quiet through the rest of the body. So just to make this a little quicker, because I want to not run out of time on you guys, this is me. So that guy back there, but a few years younger than I am now. So I had these kind of symptoms. Had front of the hip pain, came on for no reason. It was only in the TT or a triathlon bike. Everything else looked good. I did have trouble doing a single leg inverted leg press, and at the time wasn't sure what was going on. So a little bit of decreased range of motion at the top end, pretty tight for internal rotation. A little bit of weakness, tightness with Thomas. So turned out I had FAI and a labral tear that I didn't know about, and then obviously figured out. But I had raced with that, and it was after Ironman that years later that it came on. So the things that you can do for somebody who has that type of impingement is you can check, is their saddle too low so that they're ending up in too deep a hip flexion. You can see if the saddle is too far rearward, which would again close them down. They close down and then pinch off. And unfortunately, that tends to happen in UCI positioning. So people with impingement who are riding UCI races, they're going to have a little more challenge as a result of that. So that's where the shorter cranks for me are a really good idea. So if any of you out there, especially in the UCI athletes, are having trouble treating somebody with hip impingement because it keeps getting irritated on the bike, you could look to shorter cranks to try and fix that. And you can allay their fears that they're going to be losing power, because the data doesn't say that. A lot of people who like longer cranks don't want to mess with that. The other option would be to raise the handlebars, because that'll open up the hip angle again. Again, if you're competitive, especially at the top end, high end, you don't want to do that because you're going to be decreasing your aerodynamics. And then the other one for telling people how to manage this is mix it up between your TT or triathlon and road bike. Don't always ride on the tri-bike. So looking at this picture here, this is, I think, a great example of what a TT position would look like, that red line, and then what triathletes do, as the rules allow you, is we would move that seat forward and open you up, and it's just much nicer on the low back and the hip. For Zabriskie here, And a lot of the time trialists, they will naturally slide to the front of the saddle in order to open themselves up. The negative to that is they will close down this angle and they can end up with more strain through here. But those guys are pretty darn fit, and I'm sure they tolerate that better than guys like me. So this is a fellow that I treated last year, and actually I just saw him back in the schedule this year with something different. But he rides quite hard and a lot, and he was getting pain with going down the stairs, prolonged sitting, driving, cycling, and he had to eventually stop. X-rays were normal, mild swelling at the distal ITB. He had a positive brush test, so there was something going on within the joint itself. He had a positive Clark's. So likely he had a mix of patellofemoral and ITB issues. So for somebody like that, again, looking at saddle height, optimizing it as best you can, adjusting the cleats to widen them out and take the stress off the ITB. A lot of these things are trial and error. And then I put in there that what about moving the seat forward and back? Well, research seems to indicate that that doesn't affect knee pain. So that kind of explains why triathletes haven't ended up with a ton of patellofemoral, because they often ride slammed forward, you know, well beyond or at the bottom bracket for where the nose of the saddle is. So in summary, if you have somebody, a patient coming in and they haven't had a bike fit and they're going through issues, then it would make sense to have them see somebody who can take them through the process and optimize it and try and reduce the strain. If they have had a bike fit, then it's good to ask some questions, and not that you're going to have this all memorized, but with some of their answers coming back, you'll get a sense of how thorough that fitter is and whether you think that they've done a good job or maybe they need a second opinion. The other option is to send them back to that same fitter and tell them, hey, we're having issues, because I know people that come to see me, I follow up with them in 4 to 6 weeks after the initial fit to make sure things are looking good, optimize it a little bit more. But I also want them to come back to me if there's issues down the line as well. And just some suggestions for bike adjustments for FAI. You want to maximize that saddle height, test shorter cranks. I have two fit bikes, and they come with adjustable cranks, so you don't have to go and buy them to see if they work. You can test them because you can mimic the person's bike with one of these, and then if they feel that significant difference, just like you saw with me on that video there, that gives them confidence to make that purchase. For patellofemoral issues, seat height's always the first one to check. You can look at the foot positioning and adjust for also hip width. Thank you, everyone. I appreciate your attention, and I hope you got something out of this talk.
Thanks, Richard. We're just going to get to the questions because we're running a little bit behind, but we got 4 questions there. And then if anyone else wants to put any in the Q&A, I'll let Richard can respond to them individually after.
I'm not much of a cyclist, but just in case I take up the sport, how would I find a reputable bike fitter? I mean, you can always use Google to see what people's ratings are. Some people will have designations, like Retool is a pretty popular one. Although great tools doesn't necessarily mean you're going to get great results, because that one study that used the 3 riders out at 9 fits, a number of them were Retool, and when you look at the scatter plot, they were part of the data that was kind of all over the place for the parameters they were looking at. You know, if you can make connections within the cycling community, ask around and see who's done a good job. You can call and quiz them on what their process is. If they say, oh, you're in half an hour, I wouldn't do that. I'd look a little farther. What is the name of the shareware, and is it available for iOS? I think it is available for iOS, but I don't know for sure. And it's called Kinovia, Kinovea. If you want to shoot me an email, I can get that to you, Rich, as well. So yes, the video is through a sport camera, and if you center it as best you can, it'll minimize those negative effects. There are tools that can reduce that parallax, and that's something that I have to bring on board because it's a new tool that I've been utilizing. But I think the way, if you can set up nice and parallel to your subject, it minimizes that as well. Thank you very much, Connie. I appreciate it. Can you make a comment on bio-paste chain rings? I'm not sure that that's true. Now, I've heard the name bio-paste, but I think they are the ones that are elliptical. And the research that I've looked at elliptical is that I don't think they made much of a difference. That being said, if you had a chance to try them and you felt like, because the theory is that it helps you get through the top dead center better because it's a smaller diameter at that point because it's shaped like an oval. But I know they were in vogue for quite a while and they come back in and out, but I don't know that long term they're worth the money.
So thanks, Richard. There's a couple other talk questions there. I'll just leave those for you. If you want to even type the answers to them, that would be great.
I didn't scroll down. Yeah.
Yeah.
Okay. Yeah, I can answer them. I can type to them.
And we'll just move along to the next talk.
Okay. Thanks a lot, Wade.
Okay, so next speaker is actually me, so I'm just going to pull up my screen. Okay, so my topic I decided to speak on was to talk about saddle sores. Oh my aching, as you can see from the picture there. A lot of what I'm going to talk off follows nicely with what Richard was just talking about with Bike Fit, but we'll get into that as we go along. So just a little bit of background. This is one of the first bikes called the Bone Shaker, had metal rims and wheels, and obviously created a lot of stress, and you can see why you may get some different injuries to the saddle region in a bike like this, but bikes have evolved a lot since then, and as we've seen throughout the four talks, their bikes come in a whole bunch of different shapes, styles, geometries with different stresses on all kinds of different parts. And as we'll see, saddle sores can be related to different geometries of bikes, as well as a number of other factors. So what are saddle sores? So saddle sores are a whole bunch of different things. So it's not one particular injury or area. So it can be painful pubic bones. And people talk about genital numbness, folliculitis, and skin friction type of syndromes, traumatic urethritis, vulvar trauma, UTIs, scrotal hypertrophy, vulvar and labial hypertrophy, impotence, questions about whether it causes problems with fertility. It can encompass a whole bunch of different areas. So it's not one size fits all. And what are some possible sequelae? So you can get cellulitis, abscesses, folliculitises, pudendal neuropathies, again, a question of male infertility, labial hyperplasia and perinodural cysts. I actually read a case studies where they actually did partial labial resections on a couple of female cyclists who had persistent problems as a treatment for it. So it can go to that extreme for some people, and inability to train or ride. So really, how big of a problem is this, or is this something that just you hear about occasionally? Well, back in the lead up to the 2012 Olympics in London, this was in one of the local newspapers in London as a headline. So as you can see, scientific rigor helped Team GB saddle sore cyclists on their medal trial. And kind of what they found is just the backroom staff, not even the medical staff initially, were hearing grumblings about pain in the nether regions of their female athletes in particular, becoming a big issue for them, and started to look into it a little bit further. Their first thought was to put a ban on bikini waxing and adjustments to saddle angles, and found that that made a big difference. Following up on that, British Cycling did a survey to see how big of a problem it was, and found that after the London Olympics, 100% of the female athletes they interviewed had ongoing problems with saddle sores. But one of the big issues was they felt too embarrassed to mention it to their male doctors, coaches, or physiotherapists, and just basically put up with the pain or ended up taking time off riding until things healed. So not the ideal way to deal with a potential problem, but this is very common, as we'll see. So a little bit closer to home, with our track women's endurance team, we ended up doing a 2-year survey to see how this issue is affecting our female athletes in particular. And found fairly similar findings to what Team GB and British Cycling found. About 75% of our respondents reported having suffered saddle issues in the past year. 67% had modified training due to the saddle issues. 57% missed training due to saddle issues, and 43% experienced issues monthly or more. And the biggest issue is that this is, for our group, this is common amongst surveys, not just in Canada, but around the world, that this is the second most common cause of lost training days. So we do have a problem, and can be a very big problem, and it's a very common problem for riders, and needs to be addressed so that you can minimize not only the medical effects, but also the effects on training for these athletes. There is a big reluctance to talk about these issues amongst athletes, as noted in a couple of those previous quotes. We see that amongst our own athletes, it's a very sensitive area, and not necessarily people want to talk about it. So as we'll see at the end of the talk, we developed some tools to try and be a little bit more open and address these issues a bit more proactively and make it a bit more of an open environment. And the good news, there are lots of options. So I just want to look at first some of the contributing factors, and we'll go through just some studies that have been done, and there's actually been quite a bit looking at the different areas we're going to look at. So first, break it down into training factors. So things you can consider that might be causes: rapid or substantial increase in training volume, changing saddle and positions, so switching from a road position to a track position to a time trial position, all create different stresses. Longer riding times without breaks. Cycling discipline has been associated with saddle sores. So again, longer road riding, time trials, and same for triathlon time trial or triathlon bike position as well. And endurance riding is at a bit of a greater risk than the shorter track events and mountain bike. Mostly due to a couple of factors: prolonged hours in the saddle, and also bike setup. Just feeding off of what Richard was just talking about. And then there's technical factors. So poor fitting or worn chamois, type of chamois, inappropriate seat height, seat design and type, and poor bike fit. And we will go through all of these in a bit more detail, but just giving an overview to start. And then personal factors. So leg length discrepancies, pelvic asymmetries, lower back lumbar spine issues, wearing chamois for long periods of time without changing them. Poor hygiene and scaping of multiple types, especially if doing things like waxing and shaving regularly in areas of high friction has been associated with development of lots of skin issues in the area. So what do the studies say? So I sort of broke this down into a few different parts. So one of the big issues to hear from a bit more from amateur cyclists, but is there going to be an impact on sexual function, impotence, and fertility and whatnot? So there was a couple of good studies done. The first one at the top of the screen's about 3,000 athletes, and these are all female athletes, and the bottom one is about 3,000 athletes of male athletes. Both of them found fairly similar appropriate conclusions. So basically found that cyclists have a greater chance in the study of UTIs and genital numbness, And the more higher level and higher intense cyclists had a greater chance of these factors, but much less likely to report any sexual dysfunction. With a male athlete, genital numbness again was proportional to intensity, not associated with any worsening of sexual function. There's some conflicting studies on incidence of impotence, and a couple slides coming up on that as well. This study looked a little bit into handlebar height as well, and looked at that having a handlebar height lower than saddle height increased your risk of genital numbness in saddle sores in general. Factoring along with that, this specifically was looking at impotence and nerve entrapments in long distance amateur cyclists back in '97. Found impotence rates are still very, very low in cyclists, although in this study we're just slightly above what average healthy non-cyclist population would be, but still very low. Duration of symptoms seem to correlate to the number of continuous hours in a saddle, and this is some of the earlier work done on factors involved in developing saddle sores. Found that ischemic pressures on the pudendal nerve tend to resolve quite quickly, but if they actually get demyelinating symptoms, they actually did some funky testing to pick up demyelinating symptoms that can last for up to 6 months or longer. So you can have prolonged symptoms. And looking at the family planning and reproductive health side of things, basically summarized in general from the limited studies that have been done on fertility, cycling does not seem to have any long-term effect on fertility, but can cause transient impotence and genital numbness, which fits with the previous studies that we've been looking at as well. So in terms of nerve impingement, entrapment syndromes, just a bit of anatomy. So the pudendal nerve is basically the nerve that tends to get impinged in cyclists. So back to anatomy class, it travels closely to the lateral portion of the ischial tuberosity through a canal called Alcock's Canal, which is that this area here, this little tunnel trapping through there. There's pudendal nerve and artery travel through that canal, and both of them can be prone to getting pinched or impinged in that area. So you can get ischemic or neurogenic symptoms, or you can actually get both. And that gets back to that slide that was talking about the ischemic symptoms tend to resolve a lot quicker, but if you have neuropraxic type of injuries and neurogenic symptoms, the symptoms of numbness can last quite a bit longer. And just the positioning of that and thinking about how you're sitting on a saddle, you can see why that area can be prone to getting trapped and pinched. So what can we do about that? So how do we start sorting through what options there are to look at these issues and how to address them? So saddle considerations. This is just a very small sample of the saddles that are available. You have normal traditional saddles, ones that are a bit wider in the back, split saddles, ones that have a cutout in the middle. There's sort of two-prong type saddles, which are a bit more of a split one, all with different theories about and decreasing areas of stress on the saddle and perineum in particular. But does one size fit all? Definitely not. First things you have to look at is the type of cycling your athlete's involved in. So as the diagram showing below, and certainly makes sense intuitively, the more upright position. So if you think about something like a beach cruiser type of bike, which is very upright, you're sitting much more posteriorly, and the stresses through the perineal area tend to go through more the lateral and posterior portions of your ischial tuberosities. And as you move into more of the forward positions on your bike, from mountain bike to road to a time trial type of position, basically the stresses get shifted a bit more interior and narrower pressures, and also more interior on the ischial tuberosities. Also some differences in female versus male anatomies. Pelvises aren't the same size for both, as we know, so there are some individual differences in that as well. And your saddle design, keeping in mind these different bike positions, will affect where the pressures are. If you're more upright, you probably want a bit of a wider saddle in the back to get a bit more support over the isc tubes, whereas if you're much more on the front, you're going to be looking at much more of a narrower type of saddle. What about saddle setup? This gets, Richard didn't talk about this part on his talk, but just getting back to bike fit. There has been a couple of studies looking at actually saddle tilt. This one in particular, and other studies find similar results, that a slightly downward saddle tilt may be more comfortable, particularly on uphill gradients. Basically what you're doing is you're alleviating the pressure in that when you're in that anterior portion of your saddle on the perineum and genital areas. This is going to be much more of a comfort issue, and also if you put too much of a downward tilt, they're going to have a tendency to be more slipping off and potentially lose some power while they're riding in there. So this is very much of a working with the individual athletes on what works best for them. Pressure mapping is a bit more of an advanced technique for looking at different areas of pressure, obviously. So this is used for a couple of reasons. It can be used for actually identifying a particular saddle. There's a group actually out in a company out of Vancouver that actually will make you custom saddles based on saddle pressure mapping. So as you can see by the different postures, again, that more leisurely ride versus the very aggressive and aerodynamic rides, your pressures just more scientifically demonstrates that your perineal pressures tend to be much more on the anterior portion of the saddle in that aggressive aerodynamic position, and a much broader distribution of your forces in that more leisurely type of position. Just as a little bit of an aside, some of our coaches with our teams use pressure mapping also to identify individual variances in our athletes and work on fine-tuning their bike setup more from a power perspective than a power and efficiency perspective than from a saddle sore issue, but they do overlap, obviously. And then what about chamois? So most cyclists are using shorts with different types of chamois, and there is a whole lot of options out there to potentially try. They vary in shape, area of padding, thicknesses, density of the padding, just overall size of the chamois, and there is no one size fits all for this. But this too has been looked at in a number of different studies as to what might be the most effective, to give us a little bit of clues as to what you might want to try. So back in 2015, this study looked at two things. It basically looked at 3 different types of chamois, varying thicknesses and densities. And for their outcomes, they had an objective measure of measuring the actual forces applied to the perineal area using pressure mapping type of sensors, and on the saddles as well, so both of those. And they also just looked at subjective comfort scores, just subjective ratings as to how comfortable the different types of chamois were for the individual subjects in the study. So the first one was basically a thinner chamois with less dense, so a bit softer, less dense chamois pad. Then there's an intermediate one, which is a bit thicker of a chamois and had a medium, what we rated as, they rated as a medium density of the foam in the chamois itself. And then again, the same thickness, but a higher density component. And when they looked at the mean peak pressures, they found that the lowest mean peak pressures, both in perineal area and on the saddle, were for that intermediate zone. So the ones that are thicker and have a medium density. But interestingly, the subjective comfort scores didn't necessarily correlate with that. So although the pressures were lower in that area, they weren't necessarily what the individual subjects preferred and found the most comfortable. But it's a good sort of starting point to look at if you're looking at starting to trial a chamois in that intermediate zone. So what does this mean practically? So the science suggests that a thicker medium density equals less pressures to the perineum, but just keep in mind the subjective comfort doesn't necessarily follow that, and there's always individual factors with that, and often requires a bit of trial and error to see what an individual person likes the best. Other factors, not in this study in particular, but just in general, you want to look at location of padding and particular what type of bike the person's riding. So do they need more cushioning over the ischial tuberosities or on the inner thigh area or on the perineal area if they're in that very forward, more aggressive position, type of material used. It can be a factor as well. Riding position may do better with specific chamois design. So again, more upright, you'd probably want more cushioning posteriorly. And that forward position, you're going to want to look at chamois that in theory will provide less friction and more support in through the genital perineal area. And just individual factors are hard to quantify for them. We find just differences within same athletes, same team, same bikes, same positions, and they can all prefer different types of chamois for their comfort as well. How does handlebar position impact on this? So again, just thinking through the geometry. So individual bike setup is key, as Richard was also talking about, also for prevention of a number of other injuries. But handlebar position impacts your pelvic position on the saddle. So the lower your handlebar position is in relation to the seat, it's going to change the tilt of your pelvis and also change the pressures on your perineum. If your handlebar position is higher or more level with the saddle, it's going to shift you to a bit more posterior portion of your pelvis. And if you're in that lower drop position, it's going to shift the pressures much more anteriorly and shift you more anterior on the saddle itself as well. So this is very dependent on the discipline. You obviously can't be doing a time trial on a beach cruiser style bike position. So some of this is changing around the handlebars position has some limitations to still participate in that discipline effectively. But small adjustments may actually translate to bigger benefits for the athlete in particular. Just furthering on that, the study looked at handlebar level and did the damage to pelvic floor in female cyclists. So it just reinforces what we've been talking about, that women who rode with handlebar position lower than the seat had an increase in perineum pressure and noted significantly decreased sensation in the anterior vagina, but no changes in labial sensation with that lower handlebar position. And again, just talking about how the different lower handlebar position, how it impacts on your pelvic tilt and increased pressure in the perineum. This didn't look at handlebar reach distance or actually saddle tilt, which are also factors that could impact if you do have to have that lower handlebar position. Changing your saddle tilt or the reach can affect also those pressures. So this isn't taking that into account as well. So just want to talk about some key takeaways. So saddle sores, they are a big problem. They're probably very underreported for various reasons, mostly due to a lot of athletes or just don't want to talk about issues in their nether regions, as GB Cycling pointed out. And it's been our experience as well. Athletes are pretty reluctant to talk about it. So creating that open environment and an area where they can actually talk about that and feel more comfortable can certainly help in identifying these issues and hopefully eliminate some lost training days and help to resolve these issues without them becoming larger problems for your athletes. Just keep in mind, this is a number two cause of lost training days in elite cyclists. They're not all the same. To prevent and treat, you need to look at what the symptoms are and what the actual problem is before you can start addressing how to actually treat it. So in summary, change the things you can and manage the things you can't. So things you can change, technical issues, you can look at saddle type, design, saddle tilt, chamois type, different cycle shorts, handlebar position, bike setup as much as you can. Personal factors, so hygiene in general, changing your cycling shorts frequently. So if you have athletes that are doing back-to-back riding or multiple workouts throughout a day, having them change their cycling shorts and not riding in wet shorts for prolonged periods of time tends to help reduce a lot of the skin irritation friction issues, or changing out their chamois after each workout. Generally recommended to avoid waxing, shaving, excessive hair removal in the pubic area just due to the sheer friction in that area. And then training factors, so change the position in the saddle if you can regularly. So if you're on something like long road distance road riding, if you're altering your position on the saddle, certainly helps reduce those prolonged pressures in the area. Avoiding repeated long hours in the saddle if you can, and that's not always possible, but if you can't, then altering your positions during your rides can be very helpful in limiting the symptoms that you can see. And this is very discipline dependent, obviously. So things you can't change, but you can manage. So just general recommendations that seem to help. Letting the skin breathe, especially at night. So wearing loose skirts, loose fitting shorts, sleeping in the nude can be beneficial if people are having skin breakdown issues. Literature recommends that you take time off the saddle if you actually have broken skin and not trying to ride through that. Keep it dry, just general wound care. when you are training, covering an irritated area that doesn't have broken skin with cushion band-aids, Tegaderm, second skin, whatever your choice of trying to reduce the friction in that area. Using chamois cream can help reduce friction as well. A lot of our athletes prefer to use something called double base gel, but there are a bunch of different types of chamois creams around, all designed to reduce friction on the inner thigh perineal area. And also checking chamois, so some of them have loose threads that can cause wear and irritation. Or looking for signs of wear and changing them out immediately post-workout, or using a newer clean one after every workout. And then I just wanted to finish up. So after we did, and while we were doing our couple of studies and realizing this was a bit of an issue for our female cyclists, we ended up developing an infographic for them. So it's a bit of an educational tool. So we have, as part of our preseason or early in the season discussions with our athletes, saddle sores and prevention. And I found this particular infographic to be quite helpful. It basically goes over what we found in our survey, what saddle sores are, what some of the factors are, some things that the athletes can do on their own to try and prevent this from happening, or treating sort of issues that don't need to be necessarily seen by a medical professional before they become a bigger issue. And then on the other side, it does tell them when they do need to involve a medical professional, so that it doesn't, so that they can actually get back on the bike and avoid the time off. So we've actually done some feedback on this and found it to have a really good uptake. It's increased the willingness of our athletes to bring this up, usually to our physiotherapist first, and when need to get involved with the team physician going forward. So it's been a good tool going forward, and a good way to open up this as an issue to deal with your athletes. And I am going to end there, and we'll move over to some questions. So first one's from Laura. So Laura, are there plans to address saddle sores proactively, particularly in women? Should there be a female on the IST? So kind of what I was getting at the end, I think would answer that question, Laura. So yes, one of the big issues is just we have female, with our team anyways, we have female therapists, and through this educational program we've been doing for the past 4 or 5 years now, it's actually had a big impact on addressing saddle sores proactively. Just keep in mind, these do happen in men too. Men aren't always open to talking about the issues either, but they do tend to be a little bit more, at least with my experience. But do you always have to have a female? No, I think that more the key issue is having an open environment where people do feel comfortable and have options to bring these issues up. Second one from Laura, just did they look at, with male sexual issues, measure any impact on hormones? I do not in any of the studies I looked at did that happen. And then from Lawrence, do you have any treatment for cyclists with persistent nodules or cysts? So I don't have any particular advice other than what we talked about. It would be more trying to, where are they having those particular nodules and cysts, looking at if there's particular pressure points there, whether it's looking at the type of saddle they have, are they getting support in through that area with the proper chamois, is the padding in the right area to try and avoid increased pressure on that location. So I think it's looking more to the mechanical issue in that area. And is there any evidence for chamois creams make any difference? I actually don't know of any studies that specifically looked at chamois cream versus not. Certainly it's very commonly used amongst their more elite type of athletes. And most of them do seem to find that it does help. And they all seem to have their own personal one that they tend to find makes a big difference for them. And with that, I'm going to end my talk. If there's any further questions, you can pop them in Q&A and I'll respond to them. And we will move on to our final talk of the day. So it's been a long night, and we're going to end with a new speaker that wasn't with us last year. So I just wanted to introduce Mark Rocca. So Mark actually works at, he works in Barrie, and he's a sport chiropractor, in particular, a big interest in cyclists. and works at Strive Sport and Exercise Medicine up in Barrie. Works with both elite and professional cyclists quite extensively. There are a couple of the mountain bikers up that area, I believe, that Mark works with. And I'm going to let Mark finish this up with his talk.
All right, thanks, Wade. Okay. Okay, hi guys, so my name's Mark, and what we're going to talk about today is movement efficiency and how it pertains to cyclists. Due to the time limit, I deleted a lot of slides, so we'll try to get through this relatively quickly, and we'll keep it kind of fun. I've been in the game for a while now. I started digging out the trenches, as it were, in the early 90s. And after a lot of school, I ended up here in Barrie, and I've been a sport-focused chiropractor for the past decade or so now. And I'm fortunate enough to work at Strive Sport and Exercise Medicine with a pretty star-studded lineup, so I'm pretty fortunate there. Spent a lot of time, another decade or so, as a post-secondary professor in health and exercise science. I also live in Horseshoe Valley, and as Wade sort of alluded to, if you know the area, it is an absolute hotbed for cycling talent. A lot of local representation nationally and then internationally. One of the local boys actually plays very, very well in Nova Mesto today, so that was pretty cool. I live in that area for a reason. I am an avid cyclist, and I like to compete in off-road multi-sport and adventure races. And I use the word compete very, very loosely. With that, I've also had to come a fairly extensive injury history. And there's no way I'm going to read through all this, and it isn't even comprehensive, but it's just sort of what I could remember when I was putting this presentation together. And the reason why I throw that in there is because it kind of gives me a little bit of a unique perspective, because I kind of approach these cases, one, as a clinician, but also as an athlete that's had to overcome these obstacles. And I can still ride my bike, and I can still ride fairly aggressive terrain. Not fast, but I can still ride it. So I kind of like to sort of wear both hats when I'm looking at this topic. Okay, so a little bit of a segue, and this sort of gives us some information, kind of carries in nicely to the central theme. A quote from the world-renowned spine biomechanist, Professor Stu McGill, and you can't fire a cannon from a canoe. And I really, really like this because it ties in nicely. And I think my interpretation of what Professor McGill is saying here essentially is the whole idea when you're firing a canoe is you want to have maximal exit velocity of that cannonball. And that's just a release of kinetic energy. And if you're firing off an unstable platform like a canoe, there's going to be quite a substantial loss in that kinetic energy. And the end result is going to be that cannonball is just not going to go very far. If we can shoot that cannon from a much more stable surface with a lot of ground reaction force, there's much less energy leakage, and then that cannonball has a better chance of maximal exit velocity. So that's sort of the focus we're going to take today, is we're going to look at stability. Like I mentioned, I cut out a lot of slides, so we'll try to streamline this, and it won't be too, it definitely won't be a critical review of the literature, but kind of what we're looking at is sort of that next frontier where we're sort of trailblazing a little bit. And even though we don't have the evidence to support this just yet, it is coming, and I think I have a big enough sample size from my clinical experience that I can say that there is at least a strong correlation between the concepts we're going to be talking about today and how it relates to performance. So this quote here from Charlie Weingroff, he's a physical therapist in the States. I really like this definition of stability, mainly from my own confirmation bias. But essentially, if we look at stability as a description for a model that has control in the presence of change, and that being sort of the key to this quote here, it can either be efficient, inefficient, or even injurious, and it doesn't even necessarily have to yield a desirable adaptation, but the bottom line is it's just control. And then there are many, many ways to control a model. So for example, a common misconception with stability is that you need to have a strong core. And while that's part of the model, it isn't the entire thing. So, you know, for the example, if you can hold a plank for 2 minutes, you know, by most standards, that's considered a strong core, but it's very, very stiff and rigid, and stiff and rigid doesn't necessarily translate to speed. So we'll look at it through a little bit different of a lens today. So first, when we're looking at motor control, we need to look at motor unit recruitment. And we're going to sort of look at high and low threshold strategies in that context. So on just a basic review physiology here, when we're looking at a low threshold strategy, we have relatively small motor unit recruitment with little force. So in this case, we're thinking basic postural control. So on the bike, for example, you shouldn't have to be working that hard to maintain an efficient posture on the bike. But what happens as we need more force, obviously we're going to be recruiting more and more motor units. And with more motor unit recruitment, then we're obviously going to be recruiting more muscles. And with that, it comes with a metabolic cost. So every time we take a little bit of a leap and incur even just a little bit of oxygen debt, essentially we're going to be, you know, burning through ATP and accumulating protons. And in a sport where, you know, seconds and even fractions of seconds can make the difference between being the podium and not being on the podium, this is the kinds of things that we're trying to look at, so that when we're talking about just control of the bike, we're trying to do it as low of a threshold as possible. And this next slide here just sort of illustrates the same point. So again, in just bike manipulation and handling a bike, for example, like on an XCO course, we really want to be controlling that bike with as little force as possible and keep it as oxidative as it can. The further we tend to ascend up with this motor unit recruitment and start getting into type 2A and type 2X fibers, again, it's coming at a metabolic cost. So I liken this area of the graph up here to, this is where we're burning matches. And we really want to save those matches for key points in a race. So whether you're making an attack on a climb or making a push for, you know, a sprint finish, the more matches you have in the tank, then the more advantageous that is from a performance perspective. So again, when we're talking just basic stability and postural control, we want to be down here as much as we can. Now, the model we're going to look at for stabilization, we look at it sort of as integrated. So again, yes, the core is important, but the core is just one piece of the puzzle. And this has been adapted from Professor Pavel Kolash from Prague. I'm not going to list a bunch of papers here, but if anybody's interested, that is definitely a really good resource to learn more about this in a lot more depth, along with Stu McGill, who I mentioned earlier. But we're going to talk about these principles here a little bit, and the analogy that I use is stability kind of works with a group of muscles almost like they're working in series. So if we sort of think for an analogy's purpose, if you look at Christmas lights, the old ones, for example, if one bulb in that series doesn't work, then none of the lights come on. So when we're looking at integrated stabilization, we take a very similar approach where certain joint positions and certain postures will alter the muscle activity. So when we're looking, again, this is just basic anatomy review on the posterior aspect of the spine, the transversospinalis group, like multifidi, rotatorides, etc. We can almost think of these little guys and their orientation as acting like a bunch of discrete little GPS units, constantly relaying information to the CNS about, okay, where are we in time and space? And then whether it's at the cortical level or subcortical level, the body's constantly making adjustments depending on this information that's being relayed from multifidi. So the multifidi group tends to take care of the posterior aspect of the spine at the deepest level. Granted, there is a lot more musculature and it's not that simple, but for the sake of 20 to 30 minute time constraints, this is what we're going to go with. On the front of the neck, we've got the deep neck flexors, longus colli, longus capitis, etc. That's essentially like the abs or the psoas for the neck, as it were. And they're really going to sort of control what's happening on the front of the neck, from the upper cervical spine right down into the upper thoracic spine. through the thorax. I mean, that's a big bony structure, and there's a lot of pressure differentials depending on gas exchange happening in there that will attribute to stability through the thorax. But where we want to spend a bit more attention here and is through the trunk. And if we sort of take a step back to that cannonball analogy, but cycling is very, very similar, where the idea where watts and watts per kilo is kind of the gold standard. We want to maximize the amount of force that we can put into those pedals. And if we're good and stable through here, then we're really setting ourselves up nicely to maximize that kinetic energy actually getting into the pedals and into the drivetrain. But if we have any weakness through here, or if firing patterns are uncoordinated, then we're going to get a force dissipation. The end result of that is going to be, okay, we're putting less force into the pedals, but also that energy dissipation. If we think to the canoe and what happens to the water as that energy gets dissipated, other tissues are going to take up that energy. And the end result is going to be one of two things, and usually both, is that we're going to get decreased force production, and we're also going to be increasing the likelihood of those overuse and non-crash type injuries. So I think this is sort of really, really important in freeing up those hips to really smash into the pedals. Now, the way that this works, because we've got this really big bony rib cage and this bony pelvis, there's a high degree of muscular coordination to achieve ideal stabilization through here. And so if we look at it from the muscular perspective, we got the diaphragm that's going to sit on the bottom of the rib cage, dome shaped at rest. And when we inhale, it's going to flatten. And as that diaphragm flattens, it's almost like a piston action where it's going to compartmentalize the contents of the abdominal cavity. On the perimeter and all the way around, we've got the transverse abdominis, literally laps 360 degrees around. And we know that's going to be used in forceful expiration. And again, it's going to compartmentalize. And then on the bottom here, we've got the muscles of the pelvic floor, which that's going to be the foundation. That's going to support all of this. And we'll talk about how this works a little bit in this next slide. And here this is just basic physics. So essentially what we want to do is attenuate pressure and then get coordinated activity of that musculature. And if we know from Boyle's law, if we take a contained volume of space and we change the volume, the pressure changes with it. So coming back up here just for a second, if this diaphragm flattens, decreases the volume through here, we get an increase in pressure and therefore stability. Same thing with transverse. If we get good contraction of transverse while the diaphragm relaxes, then we can maintain that volume of space and therefore the pressure. So really we want these two to kind of be working together. And then with the pelvic floor, there are some tools we can use to make sure that's online. But if we are having any kind of pelvic floor issues, I am definitely not qualified to speak to that. So I'll kind of move on a little bit. But the idea is the more pressure we have internally, the more stable it's going to become. Now, this is very much a case of we need as much stability as necessary, but also as little as possible. So what we don't want to do is be rigid, because we know intuitively the more rigid we are, the less force and less speed we're going to be able to produce. So it's essentially being able to generate that pressure, but it's also equally important to be able to release the pressure. And the faster we get that release, the faster we get that recoil, then the more speed there's going to be. So I really like to look at this as we need as much as necessary, but as little as possible, because again, for basic postural control and basic stability, we shouldn't need to be burning any matches. So those were essentially the basic principles. Again, for time, I cut out a lot of slides because we're getting close to the end of the night here. But I wanted to spend most of the time that I have looking at some footage of one of the athletes I've been privileged enough to work with. And I have his permission to use his name and share the footage. So thank you, Peter. he's our current national champ, great kid. And when he's injured, obviously those are the things we kind of work on. But when he's not injured, which thankfully is a lot of the time, of note, he's got scoliosis as well as he's got pectus excavatum as well. So when we sort of think back to what we've got gone over here with the spine and with the thorax, obviously structurally, it poses some challenges. So I thought this would be a pretty cool case to present. Okay, so here what we're going to look at is we're obviously looking at the posterior aspect here, and he's down on all fours. And the reason we did it in this position is this is what we're going to see when he's on the bike. So when we're looking at the respiratory patterns, which obviously with the diaphragm and transverse abdominis are going to play not just a role in sort of pressure differentials in the thorax, but also stability through the trunk. So let me just hit play here. Okay, so when the diaphragm again descends, that piston action, what we want to be able to see, and you can see here is this lateral expansion through the trunk. So as that diaphragm drops, these false ribs will start to expand. And then we get expansion of the lateral wall through the trunk as well. So this is kind of the pattern that we want to see if we're going to be assessing this. The other thing of note, and this is where motor unit recruitment and these high threshold strategies start to come into play, is if we're not getting effective use of that diaphragm, what we're going to see in order to get expansion of the thoracic cavity in order to facilitate gas flow is cranial movements of the thorax. So they'll start to move upward, and we can't see it in this angle, but the ribs will start to flare up as well. And that's not a very ideal strategy. When we look at how this stabilizes through here, if we use the analogy of like a can of Coke, for example, or the red ambulance in the cycling world, it's very, very stiff. Even though it's aluminum and it's very, very thin walls, it can generate a lot of pressure, and that's because of the internal pressure, and it's a closed system. But if we pop the tab and we release that pressure, essentially that can will buckle under minimal load. And in order to prevent that, that's where we start recruiting other musculature to help hold down the fort or to move the thorax to facilitate gas exchange. So in the vein of being efficient, we really, really want to make maximum use of that diaphragm and get good orientation. So again, when we're looking at it, this is the pattern that we want to see, is that lateral expansion and a lack of movement cranially. The other thing that we want to see, and you'll note here, this looks really, really good, is there's not a lot of accessory muscle activity. The erector spinae group seems to be pretty good. There's no peaks and valleys, there's no shadows. And those are the kinds of things that we see when we have inadequate intra-abdominal pressure to create that stability through the trunk. So same idea here, we're just going to look at it from a slightly different angle. Sorry. So here he's getting a little settled. Now, one thing that I want to point out here, this is another common pattern that we're going to see. We can see this big rib flare here, and this is a non-ideal stabilization strategy. So when we think of the trunk as being that canister with the diaphragm, pelvic floor, and the transverse abdominis, when this rib flare and with this excessive lordosis through the thoracolumbar junction here, that core doesn't really have the opportunity to generate that intra-abdominal pressure. And this is a prime area for energy leakage, and a common area of complaint that I see with cyclists is a lot of muscle hypertonicity and discomfort in this area. And the other thing with it as well is we kind of end up in this yonda-postural syndrome here, and we get a lot of hip flexor activity. Rectus femoris, psoas iliacus, trying to lock down the lumbopelvic region because we have inadequate pressure here. But if we can kind of settle in, and then now here we've got a more ideal strategy. So the ribs aren't flaring anymore. We don't have any hyperlordosis through that thoracolumbar junction. And we can see the trunk really kind of has this kind of barrel shaped. And now this is an ideal stabilization strategy. So now we've gone and decreased that load or that energy leak through here where kinetic energy would be getting absorbed in that thoracolumbar junction. And we've also freed up rectus femoris, iliacus, psoas from having to lock down that lumbopelvic complex. That really frees up the hips and allows them to move freely and then get that kinetic energy into those pedals and maximize the power output. And now when we watch the respiratory patterns, right through here, again, now we're looking for that expansion through the trunk rather than that cranial movement of the thorax. So when we're assessing this, again, we want to see that lateral expansion, that symmetrical expansion through the trunk with respiration. And then we also, if we want to look at the clavicles, and if we see the clavicles are moving cranially, we know that something's going on. And we can see here again with Peter, there is minor cranial movement of the clavicle. And we can see here that he is using a little bit of a high threshold strategy in this case. So even though he was doing pretty good through here, it's coming at a bit of a cost up here. And I see this a lot with cyclists and this is why we have him doing this drill actually, is he's got a lot of rigidity and kyphosis through the thorax. So if we can free up that thorax, then that allows the trunk to move more harmoniously with those deep neck flexors. And then once we get that whole complex working together, that really frees up mobility. Same idea here, but what we want to be able to do now that we've kind of locked down that trunk is we need good differentiation or good dissociation of the ball and socket joints. So the shoulders and hips, they need to move. And if we get good stability through the axial skeleton and through the trunk, then that really frees us up because now we're much more lower threshold and now the power producers are free to do so. So in this drill, all we're really doing is just looking to see, because we were working on that thoracic mobility, is now can he get into a good amount of shoulder flexion without compromising the integrity of that thoracopelvic canister or through the trunk there. And he looks pretty good. Good flexion, and we need this degree of flexion probably about to this point when we're descending on the bike. When these cyclists are going downhill, there's definitely a posterior weight shift of the hips, and those shoulders have to be able to go into flexion. So this is pretty critical to be able to hit this angle for Peter while also maintaining the integrity of what's happening through the trunk. So that's sort of what the objective was on this one. So again, what we're looking at, different position here now. So is, again, we want to get good stability through the trunk and have free differentiation of the extremities. So what we're going to see here is this is a basic dead bug drill. And we're just coming across the body. And we can kind of see here, if we look closely, we do have some rib flaring here. Now, part of this is going to be structural because Peter does have a spinal curvature as well as the pectus. So again, we're not looking for perfect. I don't think I've ever come across a perfect structured athlete ever. But again, we can kind of see this. And what we're going to notice here a little bit more in this video as I kind of scroll through is on this one here. And again, we can really sort of see that apex here he's gonna complain about a little bit of impingement that was happening here. And this was a really, really classic case of using that high threshold strategy where if we're not getting adequate stabilization through the trunk, then we're going to recruit more musculature, we're going to recruit more motor units to get the job done. So in this case, again, we got psoas, iliacus, and rectus femoris. They're not only trying to bring that hip into flexion, but they're trying to lock down that lumbopelvic complex. So you'll see here on the next one, he's going to reset, if you watch closely with the breath there. So now he's locked down. That apex is much, much better. And then he's locked down. So apex is gone. This is a much more ideal looking scenario here through the trunk. And then bang. Much more hip flexion, and the audio is not on this one, but the pain did go away with that. So this is a very, very common one I see with cyclists with chronic hip flexor issues. I mean, we can stretch them, massage them, ART them until we're blue in the face. But sometimes it's just as simple as just sort of correcting the strategy here. And if we get this good proximal stability, then distally, we get a lot more mobility out of it. So I find as a general rule, if we fix this, and then a lot of other things kind of shake out on their own. So similar position again. Now what we're going to be getting into here, so the last one with the hip flexion is a little bit more of the pedal stroke. Now we're going to be looking at turning. And part of what we're looking at when we're looking with these athletes is being able to identify, okay, where are they having issues? Is it on cornering? Is it descending? Is it climbing? And that kind of gives us clues on where we need to look to find these little inefficiencies. So we're going to see on this, oops, sorry. Fat thumbs. Okay. So in this one, we're going to look at turning, and now we're getting out of the sagittal plane here, and we're getting a little more transverse and frontal planes. So now we're reaching across, and now we're getting a little bit more muscle recruitment. So now we're not just relying on those deep cervical flexors, the transversal spinalis group, and through the trunk. Now we're integrating oblique slings. And with this turning, again, we're looking for support on the one side. So that this would correlate with a left-hand turn. And we can see here, we've got this rib flaring. And we can see how really he gets a little squirrely on this one and has a hard time holding it down. As I kind of sort of scroll back and forth. And now we've got some more significant rib flaring, and we've got some depressions in here. So what this is showing us is that we've lost that internal pressure in here, and now we're going big time into some high threshold strategies here. So now the hips are going to start tightening up a little bit because we've lost that control through the midsection. And again, we can see there again where that rib wants to pop up. So I came in incorrect, and just a little bit of pressure there. Respiratory patterns start to normalize to some degree, but it is still pretty squirrely. So now that we're getting into some of these higher level patterns, this is where things are going to kind of break down a little bit. So this is a good example of something that we need to work on. And by virtue of the scoliosis and the spinal curvature in this case, there's already going to be a little bit of a firing issue when it comes to those oblique slings. So there's no surprises that this one was a little bit challenging. So back to more turns here. So I apologize, I don't have an on the bike picture, but for those of you that are familiar with the sport, again, this position here is going to be very much turning to the left. And when we take those really, really tight, hard corners, we use that knee and that lateral vector to set the stage for the body to kind of follow around the corner. So we identified in the previous video, okay, we've got a bit of an issue when we're looking at a stability from an ipsilateral support perspective. So now we're gonna explore it a little bit more here. And again, we're getting into a higher pattern. We're going to notice right away those ribs, that apex, that's clear as day. So this trunk is not using a very efficient strategy. We're going very high thresholds. And we can, even if we look down here at the foot, we can see he's gripping with the foot. So this shows us how much more muscle irradiation is being required for something that should be very, very low threshold. So again, every time he's taken a corner and the sketchier they get, that's energy loss. And again, the other thing that you'll notice, it's challenging, it's difficult, and he has actually stopped breathing and he's holding his breath. So not ideal there. So we want to make sure that he stays breathing and nice and relaxed. And the more relaxed we can breathe, then the more vagus nerve we get and the more parasympathetic we can get. And that will help this chill out a little bit. Okay, so now we're getting into some loaded, we're getting that upper extremity in the closed chain now. So this is essentially very similar to the attack position on the bike. And definitely once we start getting into some descents, this is a stability pattern that's going to be quite critical. So as usual, Peter's going to spend just a little bit of time kind of getting into position here. We got some significant rib flaring. And this is another common thing, if I can draw some attention here, that I see with cyclists. And these cycling specific adaptations is this lordotic reversal in the lumbar spine. So we really want to get the ribs in a good position. We want to normalize that lumbar spine. And then here we are. So this is really, really good. Relatively flat-ish through the trunk here. This kyphosis and the subsequent lordosis of the cervical spine, again, this is cycling adaptation. I don't see it as much in multi-sport athletes as I do with the ones that have just cycled their whole lives. So I think that's just probably one more nail in the coffin of early specialization, but I digress. So here, again, we're looking at the trunk, and this is a good canister formation. And then if we watch him breathing, and as we're looking at, there's that lateral expansion. So again, this isn't perfect. This is a higher level challenge. We're recruiting more muscle because now we're working in the closed chain. But we're looking at that respiratory pattern, and we can see as I scroll back and forth, he is getting that lateral expansion, which is what we want. Okay, just a couple more videos here. I know we're a little time crunched. So these ones are going to be a little bit more challenging. And again, so now we're supporting from the hands. So we're getting, again, more dialed into cycling specific. When we're assessing this, again, we want the back to be relatively flat, given the adaptations that occur from cycling. But most importantly, again, is this trunk. And we can see here, again, we've got a very, very nice canister formation. And when we watch the breathing, as he kind of gets a little more settled in here, is that lateral expansion or symmetrical expansion through the trunk. And we're not getting any cranial movement of the thorax. So again, this is very good. This is low threshold. We're going to take it up a notch here a little bit. And now we've gone and elevated the knees. So we're increasing the stability demand. And again, respiratory patterns in this case are looking pretty good, I think. But we can see with this higher position how he likes to go back into that lumbar or that lumbar kyphosis there, which as we're going into that lumbar kyphosis does alter the position of the pelvis. And then the hips are going to be 100%, that femur is 100% at the mercy of what the pelvis is doing. So whether it's going into an anterior tilt or a posterior tilt, it will change the muscle sequencing of what's happening in the hips. So best case, we want them here. And we want that flat, and we want very good expansion. So this here, now we're settled into a better spot. And then why not make it a little bit more challenging? So this would be, you know, this is riding the bike. This is kind of riding the bike on the flats. Last video, last pattern is going to be looking at our descending pattern. And this is the sketchiest. This is the scariest. This is where there's a lot of features. This is where things can really break down. And what we're going to watch here, so we're elevated again. So now we're just support on the extremities. And we can see we got relatively good stabilization through here. And now, as we know, when we descend on the bike, we're going to go through a posterior weight shift. So we need to get the hips back because we always want to keep our weight centered over our bottom bracket. So on those descents, the bum's going to go back, and then we're going to rely on support from the upper extremity. And now here we've got that rib flare. That's not ideal. So again, this is where we're going to run into some hip flexor issues. As we get settled in, this is where we want to be. Again, barrel shaped, there's no rib flaring. And when we watch the respiratory patterns, there's no cranial movement of the ribs. But again, we're challenging, and we're getting a little bit of lack of hip flexion here, which is now going to be creating that kyphotic moment through the lumbar spine. And now, just for fun, we're going to throw in some single arm support here. And from last week, I think it was Bruce was talking about Tara's rules. Mountain bikers walk on their hands, and we can kind of see that's happening right here. Now, this is very, very challenging. Even though things are breaking down, he does this make it look a lot easier than what it actually is. But we can kind of see here, again, there's lots of breakdowns. So whether we're looking to increase economy for the sake of being faster on the bike, or whether it's from an injury management or prevention perspective, now we're getting some information that's going to kind of guide our next steps here. So almost done here. So this is a 7-week progression. So the picture on the left, this is the first week. This is best case scenario. So this is, we've done some manual therapy at this point, and we've done some activation drills, a lot of the ones we just looked at. And this was the best that he was able to create that canister formation through the trunk. So when we look at it, again, we can see that kyphotic spot that we saw in the lateral view. We see this hourglass, which is essentially like a crushed can. So in this case, we don't have good position of the pelvis and the ribs relative to one another, compromising the ability to generate and sustain that intra-abdominal pressure. And then these peaks and valleys again are suggestive of, okay, now we can see where there's going to be some tissue overload. Conversely, 7 weeks later, after doing the work, and if there's one thing I can say about this athlete, he does the work and he does put the time in, and we can see the end result here. So again, he doesn't always look this good. This is still best case scenario versus best case scenario, but I think you can see there's quite a dramatic difference here. So we've got a very, very good canister formation, a good healthy relationship from the pelvis to the thorax, which again, pelvic position will have a big influence on what the hips are doing. And similarly, up in the upper extremity, that rib position will have a big impact on what the scapulae are doing. So this looks awesome, and you can see there's really no energy leaks here. So when we're looking at these, and again, just the last couple slides here, these motor patterns, they've been learned over time. So what we need to do is consciously go in and change these patterns and these movement stereotypes. It's going to be slow. There's going to be a lot of cueing in the beginning. These videos that I showed of Peter, those didn't happen overnight. He got really good at those over time. But the idea is we want to get to that subcortical level of control where it becomes automatic, it's reflexive, and we don't have to think about executing the movements anymore. And then once we're here, then there's some other cool things that we can do that are beyond the scope of this presentation, with mindset and visualization techniques and et cetera. But this is the progression. We need to sort of regress and then progress back to here again. Now, when we're looking at these, I mean, there was a lot of high-level patterns there, but the one plane where we can focus most of our efforts is in the sagittal plane. And I see this a very large sample in clinical practice and some of the workshops I've done in the past, where once we gain control of the sagittal plane, it really sort of opens things up for the other planes of motion. So again, Peter, even though there were some breakdowns, if we want to be really, really critical about what we saw in those videos, he made those exercises like way easier than what they actually are. And I can tell you, and he would tell you the same, that when we first started doing these and he didn't have good control with the low threshold strategy of that sagittal plane, the other exercises, some of them were impossible and he couldn't even do them. But he put the time in, gained control of that sagittal plane, and then the gates just opened wide up, and then he all of a sudden was bang, 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 able to do all these other cool things. Now, when we're looking at this again, we need to sort of regress to a level of competence, and 99% of the time that's going to be, let's bring it back to the sagittal plane, whether it's prone or supine, and let's get those respiratory patterns dialed in, get them dialed at a low threshold strategy. And then once we're there, then we build capacity. So in this case, Peter, he's got sagittal plane. We're moving on. And you can see from the videos where the breakdown occurred was the cornering and the descending. So those are the patterns that are next up on the list. Now, a lot of nitty gritty details, a lot of finer points. And I ask myself this question all the time, like, what is the point of diminishing returns? Like, how much of this do I have to do? And honestly, I don't have a good answer for that, other than every individual athlete is an individual athlete. But I can almost say with 100% certainty that gaining control of the sagittal plane with those low threshold strategies is most definitely in this most productive part of the curve. And if nothing else, if we master that, everything else gets better. How much further we want to go on this continuum, that's an individual thing. So it really depends on who you're working with. Someone like Peter, he eats this stuff up, he loves it, he puts the time in and he gets good at it. And I've had other cyclists that are like, just fix me and let me ride my bike, which is fine too. Okay, that's it.
Thanks, Mark. That was great. I don't see any questions right now, probably partly because it's been a long night, but that was a fantastic talk. I very much appreciated and very informative for that. So just, it has been a long night. I just wanted to say a couple of housekeeping items to everybody. Thank everybody for attending our 4 sessions this year. And I also wanted to thank Chasm for putting this on. It's very much appreciated. There is one question there. I will just come back to that in 1 sec, Rich. Just a couple more housekeeping items. Helen will be sending out evaluations tomorrow, as well as your CME certificates. Please, we do appreciate the evaluations, so please try and fill them out and return them. And I just wanted to thank you to all of the presenters over the 4 weeks. Very good talks throughout the weeks. So a couple quick questions there, Mark. Rich Trenholm just said, awesome talk. A lot of that based in FRR?
No, that's not based on FRR. I am very familiar with Dr. Spina's work. The FRR is more, from my understanding anyways, is more in the mobility world. So if, for example, if we're finding issues with say we really can't gain control of that thoracolpelvic canister, and maybe that's due to a hip mobility problem, or maybe that's due to a thoracic mobility problem, that's when the FRR principles would be really good. Free that up, and then once we remove that mobility limitation, then these exercises will become much more effective. A lot of this work is based on the work of Stu McGill. I think most people know who Stu McGill is. And then as well as Pavel Kolosh out of the Prague School of Rehab. A lot of really, really cool stuff coming out of there.
Okay, and just we will end things there. Helen did just post something in the chat. If anyone would like to provide feedback now, please click the link that she's posted in the chat, and otherwise evaluations will come out. Otherwise, thanks again for everyone attending our session. We'll be looking to do this again next year and appreciate the feedback on making the program better every year. Thanks everybody.